Welcome to our video on myeloproliferative disorders. Let's begin. In this lecture, we will talk about the myelodysplastic syndromes and essential thrombocythemia. For each condition, we will discuss the definition, causes, clinical presentation, diagnosis, and management. Let's start with the myelodysplastic syndrome. Myelodysplastic syndromes, MDS, are the myeloproliferative disorders characterized by ineffective hematopoiesis and disrupted maturation of non-lymphoid lineage cells. Immature red blood cells, white blood cells, and platelets stay in the bone marrow. Myelodysplastic syndromes are accompanied with the risk of progression to acute myelogenous leukemia. Myelodysplastic syndromes are commonly caused by de novo mutations. The most common chromosomal defects include deletion of 5q or 7q chromosomes. However, please keep in mind that there are many more rare chromosomal defects implicated in the pathogenesis of the myelodysplastic syndromes. Additionally, environmental exposure to benzene, radiation, and chemotherapy like alkylating agents, platinum agents, and etoposide have been shown to induce myelodysplastic syndromes. Let's talk about the clinical presentation of the myelodysplastic syndromes. The patients typically have pancytopenia, that is anemia, leukopenia, and thrombocytopenia. Anemia manifests with fatigue, shortness of breath, and exercise intolerance. Leukopenia, on the other hand, causes increased risk of infections. Finally, thrombocytopenia manifests with petechia, purpura, and mucosal bleeding like epistaxis. This is what petechia looks like on the skin. Please note the dark red macules indicating bleeding in the skin. Let's move on to diagnosis. First, as we already mentioned, myelodysplastic syndromes are characterized by pancytopenia because immature cells stay in the bone marrow. Therefore, the complete blood count will show decreased red blood cells, white blood cells, and platelets. Peripheral blood smear will reveal the pseudo-Pelger-Hewitt anomaly. This is the presence of neutrophils with bilobed nuclei on the peripheral blood smear. Let's recall that the normal amount of lobes in the neutrophil nucleus is anywhere from 3 to 5. Additionally, bone marrow biopsy will reveal the hypercellular marrow with less than 20% blasts. This is in contrast to acute myelogenous leukemia, which is characterized by more than 20% blasts on the bone marrow biopsy. The bone marrow biopsy may also show ringed sideroblasts in the patients with myelodysplastic syndromes. Finally, genetic testing for 5q and 7q chromosomal deletions can also be performed. This is what pseudo-Pelger-Hewitt anomaly looks like on the peripheral blood smear. Please note that this neutrophil has 2 lobes. This is the bone marrow biopsy from the patient with myelodysplastic syndrome. You can appreciate the hypercellular bone marrow with immature cells of the myeloid lineage, also known as the blasts. Here are the megakaryoblast, and these are the erythroblasts. The management of myelodysplastic syndromes includes supportive therapy such as red blood cell and platelet transfusion. Vitamin B6, B9, and B12 can be supplemented to facilitate hematopoiesis and cell proliferation in the bone marrow. Additionally, chemotherapy can be administered. Finally, stem cell transplantation is potentially curative. A 50-year-old woman presents to the office with severe fatigue and recurrent episodes of nosebleeds for the last 6 months. She has past medical history of Hodgkin's lymphoma treated with chemotherapy. Complete blood count shows pancytopenia. Bone marrow biopsy reveals hypercellular marrow with less than 20% blasts. What will most likely be seen on the peripheral blood smear? This patient presents with severe fatigue and recurrent episodes of nosebleeds for 6 months. Fatigue may indicate anemia, while episodes of nosebleeds may suggest thrombocytopenia. Complete blood count shows pancytopenia. Bone marrow biopsy reveals hypercellular marrow with less than 20% blasts. This description is consistent with the diagnosis of the myelodysplastic syndrome. Myelodysplastic syndrome in this patient was likely induced by chemotherapy for Hodgkin's lymphoma. Peripheral blood smear in patients with myelodysplastic syndromes commonly shows pseudo-Pelger-Hewitt anomaly. Pseudo-Pelger-Hewitt anomaly is the presence of neutrophils with bilobed nuclei on the blood smear. Let's finish off this lecture by discussing essential thrombocythemia. Essential thrombocythemia is the myeloproliferative disorder characterized by malignant proliferation of megakaryocytes in the bone marrow and subsequently increased platelet production. 30 to 50% of cases of essential thrombocythemia is caused by an acquired JAK2 mutation. JAK2 gene codes for the Janus kinase. Overactive Janus kinase due to JAK2 mutation results in increased megakaryocyte proliferation in the bone marrow. Let's talk about the clinical presentation of essential thrombocythemia. It results in both bleeding and thrombosis. This is because defective platelets either cannot aggregate at all or they form excessive clots. Bleeding can be manifested with petechia, purpura, and episodes of mucosal bleeding like epistaxis. Essential thrombocythemia may also present with deep venous thrombosis, pulmonary embolism, and acute myocardial infarction. Finally, erythromelalgia may be present. Erythromelalgia is erythema and intense burning pain of feet or hands that can be episodic or continuous. The patients with essential thrombocythemia may also present with vasomotor symptoms like headache, dizziness, and visual disturbances. This is due to increased blood viscosity from excessive platelets. Finally, acute gouty arthritis is common in patients with essential thrombocythemia due to high megakaryocyte breakdown and turnover in the bone marrow. Please recall that platelets do not have the nucleus. Therefore, platelet breakdown itself cannot increase the uric acid production, leading to gout. Let's talk about the diagnosis. First, complete blood count will reveal the platelet count more than 400,000 with normal concentrations of red blood cells and white blood cells. Peripheral blood smear, on the other hand, will reveal abnormal platelet morphology. Bone marrow biopsy typically shows megakaryocyte proliferation. Genetic testing for JAK2 mutation can also be done. This is the peripheral blood smear image from the patient with essential thrombocythemia. Please note this large platelet with abnormal morphology, characteristic of essential thrombocythemia. Here's the bone marrow biopsy from the patient with essential thrombocythemia. Note the excessive proliferation of megakaryocytes, which later produce abnormal platelets. The mainstay of treatment of essential thrombocythemia is chemotherapy. Most commonly used medications include antimetabolites like hydroxyurea and phosphodiesterase inhibitors like enalagrelide. Interferon A can also be used in the treatment of essential thrombocythemia. Platelet pheresis, which is the procedure of platelet removal from the blood, is used for emergent conditions like stroke or deep venous thrombosis. Let's try a question. A 59-year-old man presents to the emergency department with recurrent episodes of nosebleed and bleeding gums. He has a past medical history of deep venous thrombosis and myocardial infarction 2 and 5 years ago, respectively. Complete blood count is significant for platelet count of 1 million. What is the most likely diagnosis? This patient presents with recurrent episodes of nosebleed and bleeding gums. Past history of DVT and myocardial infarction. In other words, this patient has both bleeding and thrombotic episodes. His platelet count is 1 million, which is severely elevated. Recurrent bleeding and thrombotic episodes along with severe thrombocytosis is consistent with the diagnosis of essential thrombocythemia. Here's a table summarizing the myeloproliferative disorders that we discussed in the lecture. Pause the video and take a moment to consider this table. Let's conclude our lecture with a multiple choice question. A 75-year-old man presents to the ER with nosebleed for the last hour. He has past medical history of small cell lung cancer treated with radiation therapy for the past 10 years. His vital signs include a temperature of 37 degrees Celsius, blood pressure of 135/85, heart rate of 82, and respiratory rate of 16. The physical exam reveals conjunctival pallor and diffuse petechia on the skin. Complete blood count reveals hemoglobin of 7, leukocyte count of 2,000, and platelet count of 100,000. Peripheral smear shows neutrophils with bilobe nuclei. Which of the following is the best next step in the management of this patient? A. Bone marrow biopsy. B. Erythropoietin measurement in the blood. C. Thrombopoietin measurement in the blood. Or D. Chest x-ray. The patient presents with a nosebleed for the last hour. Physical exam reveals conjunctival pallor and diffuse petechia on the skin, suggesting anemia and thrombocytopenia, respectively. Complete blood count reveals hemoglobin of 7, leukocyte of 2,000, and platelet count of 100,000. This pattern is consistent with pancytopenia. Peripheral smear shows neutrophils with bilobe nuclei, a phenomenon known as the pseudo-Pelgar-Hewitt anomaly. All these findings suggest the diagnosis of myelodysplastic syndrome. Myelodysplastic syndrome in this patient was most likely induced by radiation therapy for the small cell lung cancer. The next best step in the diagnosis of the myelodysplastic syndrome is to perform the bone marrow biopsy, which will show the hypercellular marrow with less than 20% blasts. Therefore, the correct answer is option A. Here's a slide reminding us of the diagnosis of the myelodysplastic syndromes. Let's discuss why the other options are incorrect. Option B, erythropoietin measurement in blood, is incorrect because although it will be high in response to anemia, it cannot confirm the diagnosis of the myelodysplastic syndrome. Option C, thrombopoietin measurement in blood, is incorrect because although it will be high in response to thrombocytopenia, it cannot confirm the diagnosis of the myelodysplastic syndrome. Finally, option D, chest x-ray, is incorrect because although it can be used in the workup of lung cancer, it cannot confirm the myelodysplastic syndrome. And that concludes our lecture on myeloproliferative disorders.